I'm Valerie Brass. I'm the Secretary to the Review, and I'm reading a statement provided by Elaine Holmes and Olive McElroy of the Scottish Mesh Survivors. Dear Baroness Cumberledge and the Review team, thank you for allowing us to have a last say. We have been closely following the progress of the review and would like to make the following comments. With regards to medical device regulation, you have witnessed how several failed regulations have let down many patients in this country. If the MHRA had been fit for its purpose, the vaginal mesh disaster would not have happened. With regards to evidence on mesh safety, you have witnessed firsthand the failure of medical professionals to reassure you regarding the long-term safety of these mesh products. Such failure confirms what you have heard from many mesh-injured women: we are guinea pigs. With regards to surgeons' training, the NHS Digital Hospital Episode Statistics publication in the journal JAMA confirms what we have been saying for years. Surgeons' training and skills do not influence the long-term adverse events of mesh devices. The culprit is the device, not the surgeon. Please do not let senior skilled surgeons convince you of the opposite, and do not let them blame junior, less skilled surgeons for the mesh disaster. With regards to NICE, you have witnessed the confusion in its recommendations on the use of POP, that's pelvic organ prolapse mesh. We do not understand why NICE restricted the use of mesh to, in quotes, research only in December 2017, and then recommended its use outside research in 2019. What new evidence emerged in the last 2 years that reassured NICE to the degree that changed its view on POP mesh? If you fully understand this matter, we would appreciate an explanation, please. With regards to stress urinary incontinence surgery, you have seen the level of evidence that NICE relied on for their recommendations. The focus was on effectiveness rather than safety outcomes. The follow-up was only short-term, and the influence of manufacturers is quite obvious. You have also seen how some influence from manufacturers went undeclared to maintain their revenue from the use of these devices and maintain the false doctrine that vaginal mesh is safe. In 2006, NICE warned against the lack of long-term safety evidence on transobturator mesh. This year, 13 years later, NICE is restricting its use, but only after thousands of women were permanently and needlessly injured. In the same guideline this year, NICE is warning against the lack of long-term safety evidence on retropubic mesh. Please do not allow the injuries to continue for years to come until NICE decides to restrict the use of retropubic mesh. Please do not be convinced by the argument that some mesh devices are safe. Regardless of the type, all vaginal mesh devices, as a class, share the common adverse events that happen due to implanting permanent plastic material deep inside women's most intimate parts. Our first request to you is to maintain suspension on all urogynecological mesh procedures for SUI and POP, at least until evidence on long-term safety is available. Any patient consent obtained to undergo these procedures without this evidence will never be informed. In the meantime, please give the opportunity to surgeons to develop their skills in surgery that does not use mesh. This is the true gold standard that dropped several years ago in favor of using quick-fix mesh. They should not have done so. We started our campaign in 2012, and it has always been altruistic. After several years, we were successful in preventing other women from suffering the same fate we suffered. During that period, we have largely forgotten ourselves and focused on the campaign, especially as our surgeons told us they cannot do anything further to ease our pain and suffering. We now know that complete mesh removal is a reality, and we are fully aware of many success stories. Our second request to you is to ensure that every mesh-injured woman is offered the option of complete, safe surgical removal of her mesh device by a surgeon she trusts. For most of us, partial removals have done nothing except to worsen and prolong our agony. Several decades ago, the public outcry over thalidomide scandal effectively kick-started medicines regulation in the UK, and the MHRA was created. Your review has the potential to create a stronger, independent watchdog to secure patient safety and public trust without any influence from pharmaceuticals or manufacturers. The mesh suspension you have recommended in the UK must remain for the following reasons. The risks from mesh cannot be mitigated. Clinicians and clinical societies have continuously failed to reassure us how they will mitigate the risk. Better training of surgeons doesn't work, as the risk is with the mesh device regardless of the surgical skill. The risks from mesh cannot be predicted. Clinicians are unable to identify which patients are high risk of developing chronic pain and disability and which are not. It is Russian roulette. The risks from mesh are lifetime. There are reports where after several years of the good outcomes surgeons talk about, women can start developing serious injuries later in life. Not all the risks of mesh are known. There are more reports of autoimmune diseases and cancer, but the clinicians continue to deny them. The risks from mesh are irreversible. No woman goes back to her normal, even if the mesh device is completely removed. Clinicians continue to tell us the improvement rate after mesh removal is 50%. This is not good enough. The risks from mesh are entirely avoidable. The present alternative continence procedures, Colfer suspension and autologous fascial sling, are not associated with the irreversible adverse events of mesh. This makes mesh procedures entirely avoidable. If no mesh is used, a woman cannot develop mesh-related injuries. We wish you all the best of luck. Yours sincerely, Elaine Holmes and Olive McElroy.